USMLE-style question on Friedreich ataxia. Question. A 15-year-old boy presents to the clinic with progressive gait instability and frequent falls over the past year. His parents have also noticed that he has difficulty with clumsy hand movements and has slurred speech. On physical examination, he has pes cavus, kyphoscoliosis, and bilateral loss of deep tendon reflexes. Neurologic examination reveals wide-based ataxic gait, dysmetria on finger-nose testing, loss of vibratory sensation and proprioception in the lower limbs. An echocardiogram shows hypertrophic cardiomyopathy. Which of the following is the most likely diagnosis? A. Ataxia telangiectasia. B. Charcot-Marie tooth disease. C. Friedreich ataxia. D. Spinocerebellar ataxia. E. Vitamin E deficiency. Answer C. Friedreich explanation. This patient presents with progressive ataxia, loss of proprioception, absent deep tendon reflexes, skeletal deformities, and hypertrophic cardiomyopathy, which are hallmark features of Friedreich ataxia. Key features of Friedreich ataxia: gait ataxia and frequent falls due to degeneration of spinocerebellar tracts, dysarthria, slurred speech, loss of vibratory and proprioceptive sensation due to degeneration of dorsal columns, absent deep tendon reflexes due to dorsal root ganglia degeneration, hypertrophic cardiomyopathy, most common cause of death, skeletal abnormalities, pes cavus, high arched foot, kyphoscoliosis. Genetics and pathophysiology, autosomal recessive trinucleotide. GAA repeat expansion on chromosome 9 affects the FXN gene encoding frataxin, an iron-binding mitochondrial protein. Mitochondrial dysfunction, oxidative stress, neuronal degeneration. Involvement of different spinal tracts. Tract-affected clinical manifestation, spinocerebellar tract, ataxia, poor coordination. Dorsal columns, loss of vibratory and proprioceptive sensation. Dorsal root ganglia areflexia absent DTRs. Lateral corticospinal tract, spastic weakness, late stage. Diagnostic findings, genetic testing, GAA trinucleotide repeat expansion, MRI of the spine, atrophy of spinal cord and cerebellum, echocardiogram, hypertrophic cardiomyopathy. Complications, cardiomyopathy, most common cause of death, diabetes mellitus, 10%, wheelchair dependence within 10 to 15 years. Treatment, no cure. Management is supportive. Physical therapy for ataxia, surveillance for cardiomyopathy and diabetes. Why not the other options? Differential diagnosis, key differences from Friedreich ataxia. A. Ataxia telangiectasia. Ataxia plus telangiectasia's immunodeficiency, ATM gene mutation. B. Charcot-Marie tooth. Foot drop, distal muscle weakness, preserved reflexes, no conocerebellar ataxia. Progressive cerebellar degeneration, but no dorsal column involvement. E. Vitamin E deficiency. Mimics Friedreich ataxia, but occurs due to malabsorption, e.g. cystic fibrosis. Take-home point. Friedreich ataxia is an autosomal recessive trinucleotide repeat disorder on chromosome 9, leading to mitochondrial dysfunction and degeneration of spinocerebellar tracts, dorsal columns, and corticospinal tracts. It presents with progressive ataxia, loss of proprioception, absent DTRs, pes cavus, and hypertrophic cardiomyopathy. Would you like a question on another trinucleotide repeat